42-year-old man presents with a tingling numbness on the lower limbs for 2 weeks. He also complained of persistent pain in his leg, which is not relieved by over-the-counter analgesics. His past medical history is significant for type 2 diabetes for 2 years, inconsistently managed with metformin and glimepiride. On physical examination, there is a decreased sensation to the pain in both limbs, but deep tendon reflexes are intact. His vital signs include blood pressure of 122/84, temperature is 36.7, respiratory rate is 10, and his ankle brachial pressure index ABPI on right side is 1.1. His blood sugar analyze shows fasting 141, 2 hours postprandial is 235. His HbA1c is 8.1 percentage. Which of the following measure for the preventing the progression of his symptom in this patient? So what should we do to prevent the progression of the symptom? This guy is having classic presentation of diabetic neuropathy, and we should try to restrict his blood glucose control so we can decrease the progression of patients diabetic neuropathy. Let's go through some what are the clues in the question. First of all, there is a classic tingling and numbness in the lower limb for the 2 weeks. There is a complaint of persistent pain in his leg. This is paresthesia, and which is not relieved by analgesics like over-the-counter analgesic. So we can rule out any other causes like osteoarthritis, and patient is significant for diabetes type 2 for past 2 years, and is not taking his medication regularly. So there is a decreased sensation in both limbs, and deep tendon reflexes are intact. Another clue which can be seen is we can rule out any peripheral vascular diseases from this value that is given right here. The ankle brachial pressure index, that is ABPI, is usually between 0.9 to 1.1. This is the normal range, but whenever any patient is having 0.9 less than 0.9, the patient is highly risk of having peripheral vascular disease in secondary to having high blood pressure, or maybe atherosclerosis from cholesterol deposition. But if the patient is having more than 1.1 ABPI or ankle brachial plexus, then patient is having some kind of calcified vessels. This is usually seen in older patients. The ABPI greater than 1.1, the patient have calcified vessels, while ABPI less than 0.9, patient have peripheral vascular disease. So here, as patient is not having any kind of atherosclerosis or any lipid disorder, we should not give atorvastatin. There is no need of giving femoral artery bypass, as patient is not exhibiting any signs of peripheral vascular disease. His blood pressure is normal, and he's not taking any blood pressure medication, so we can eliminate the option of controlling the blood pressure, and there is no need of lower limb amputation. We prefer to go with less invasive one, that is we treat the patient's blood glucose control first. Okay. So let's go through the explanation. Here you can see diabetic neuropathy is most common cause of peripheral polyneuropathy in adults. And most common findings are numbness and paresthesia in stocking and glove distribution. And there is decreased proprioception due to degeneration of large fibrous sensory axon. Remember, the patients in diabetic neuropathy, they have degeneration of large fibers of sensory axon, and that is why the patient is having numbness, paresthesia, and decreased proprioception. So what is the pathophysiology behind this? It results from non-enzymatic glycosylation, or you can say attachment of sugar onto the protein, leading to hyalinization of endoneurial arteries. This is important. Hyalinization or protein deposition in the endoneurial arteries and causing ischemic nerve damage. So in addition to, and this leads to accumulation of toxic substance in the neuron and causes deranged metabolism and increased oxidative stress. So whenever patient has diabetic neuropathy, what other signs you look for? We look for two of the other signs. Remember, whenever patient presents with diabetic neuropathy, first, if the question is asking what is the next complication we look for, is we look for diabetic retinopathy. So in diabetic retinopathy, the pathophysiology is almost the same, but the patient have a classic phenomena. You can see a chronic hyperglycemia in the patient with diabetes can lead to increased permeability and arterial obstruction in retinal vessels, and this results in ischemia. Stimulates the production of vascular endothelial growth factor and causes them to have neovascularization, or it's also called proliferative diabetic retinopathy. And complications also include retinal hemorrhage, retinal detachment, and vision loss. So this patient, this retinopathy, they have classic phenomena of neovascularization, because remember, whenever patient have ischemia, to compensate for the ischemia, the endothelial vessels of the blood of the retinal artery, they will release a substance that is called VEGF. VEGF is vascular endothelial growth factor, and this causes them to have a neovascularization, or it's called proliferative diabetic retinopathy. So patient with diabetic neuropathy should go to see their eye doctor regularly, and they also should go to see their foot doctor. We'll see in this. So another complication of diabetic neuropathy is diabetic foot, or it's also called neuropathic foot ulcer, that occurs in diabetic patient when there is loss of pain and proprioception that delays recognition of injury. So whenever there is a loss of injury to the patient's foot, you can see if there is injury to the foot, but the sensation is not going up. This injury can form an ulcer via trauma, friction, or any pressure, and this can cause an infection, and it can cause to have diabetic foot ulcers, and then we have to amputate the leg. So the risk is greatest in the people having long-standing diabetes, who is having poorly controlled glycemic control. So what is recommended? Regular foot examination and care by podiatrist is recommended. And HbA1c is produced by non-enzymatic glycosylation, or attachment of sugar to the hemoglobin molecule is called HbA1c, and this usually circulates in a diabetes patient for approximately 3 months. And However, it can give you false positive in certain situations, like if there is hemolytic anemia, the RBCs will die sooner and it will give you low HbA1c. The risk of progression to diabetic neuropathy can be reduced by appropriate glycemic and blood pressure control. The pain due to diabetic neuropathy, if there is a pain that is this patient is having, and if it was asked what medication we can give, so there are a couple of medication we can give. One of them is TCA, that is tricyclic antidepressant, nortriptyline, and another one is anticonvulsant, that is gabapentin. We can also give one of the drug is SNRI, serotonin norepinephrine reuptake inhibitor, but these two drugs are preferred choice.
Thanks for watching. Please give a thumbs up and subscribe for more.